It's my pleasure to join you all this afternoon and give you an update on some of the things from our center, but also what's been going on around the globe with respect to the use, benefits, and safety of a variety of medications in the treatment of individuals with ASD. This first slide shows my financial disclosures. But to segue into talking about medications, I think it's really important to set the stage. Why would we even consider the use of a medication for a developmental disorder that at its heart involves things such as delays in cognitive development or delays in language and communication ability, et cetera. And to do that, I'm going to talk a little bit about where some of the early interventions and other behavioral or psychological treatments end up disappointing to some extent. And that really forms kind of the unmet need, you might say, that we consider medications possibly addressing. I'll talk with you a little bit about some of the earliest examples of what really is forming a new generation of medication studies in ASD, those that are really targeted towards the core of what we believe is responsible for ASD. That is to say, based on an understanding of its biological or even molecular basis. I'll tell you a little bit about our experience there and how we've had to learn a lot from those early studies. But I'll finish on a high note because there are examples across very diverse kinds of treatments of benefit, and there's a lot that we're pursuing here and elsewhere. I think one of the fundamental problems that perhaps all of you are painfully aware of is that not everyone benefits as much from a solid course of an intervention, whether that's 2 years of a comprehensive 30, 40 hour a week intervention program with diverse elements, including behavioral therapy, speech, educational intervention. And if you look really across the board at a wide variety of these behavioral interventions, some more limited or focused than others comprehensive, as I described, what you see is a very familiar pattern, namely the rich get richer. The higher or further along the child is intellectually or developmentally, the greater the likelihood that he or she is going to show greater gains than those who are starting more delayed with less language and perhaps even with more problem behaviors. That was painfully shown in even the Early Start Denver model pivotal trials. This is one of the most widely cited examples of what is considered a state-of-the-art comprehensive early intervention program where kids from 2 to 4 entered into this program. It's a study actually in which half of the kids were randomized to the Early Start Denver model, about 30 hours plus a week of very, very sophisticated intervention. Other kids were referred to community agencies. And at the end of 2 years, unfortunately, every single child in the Early Start Denver group still met criteria for ASD. Some had shown improvements in communication language. The biggest difference and the much touted difference related to IQ, which of course is not a core feature of ASD necessarily. Now 70% of individuals with ASD in the United States have a normal IQ. But those kids in the Early Start Denver model did gain 15 points over the 2 years versus 7 points in the community group. So a difference of 8 points, which may, at the end of the day, really reflect simply an increase in vocabulary from the intervention. In other words, there are limits even to these state-of-the-art programs. And the other aspect of the Early Start Denver studies is that, indeed, when they broke out the kids who had IQs above 70 or below, the improvement was almost totally restricted to the kids with the higher IQs from the very entry. Hence the need for us to think about what else can we do, what else can we add that might boost or kickstart these interventions to be effective more broadly. The other place in which we feel more acutely the unmet need, you might say, is when we look at the adult outcomes of individuals on the spectrum. Even more modern studies now of kids who were identified early, received comprehensive intervention, and then are followed up in their 20s, 30s, and later. The very disturbing outcomes of those surveys are that over 50% of adults are living in what's defined as social isolation. In some studies, that boils down to no contacts in the last 12 months from peers, no interaction in the last 12 months with peers, basically living a life alone. And that's even with individuals who have a lot of support, who may be living with family, et cetera. Likewise, if you look at occupational outcomes, it also is very concerning. There's just a lot of people who are not benefiting from the interventions that we're providing. Again, the rich get richer. The individuals who are from the get-go seen as less developmentally delayed tend to have better outcomes, but one striking thing from some of the longitudinal surveys of kids transitioning out of special education is that even though the autism groups now do reflect that only about 60% or 70%, or rather 30 to 40% have intellectual disability, their outcomes as far as living independently and occupational attainment and social attainment are lower even than an intellectually disabled group by itself. So there's a lot of impairment that we really need to figure out better ways to address. Likewise, we're all very familiar with the psychological or psychiatric comorbidity that serves to further impair individuals' benefit from intervention, may even lead to their placement in more restrictive educational settings or living situations. And then, sorry, the slides are getting cut off a little bit, but this is a graph from a longitudinal study that looked at adaptive skills in a group of both individuals with ASD, the majority of whom were not intellectually disabled, and also another separate group of folks with Down syndrome. And what you can see here is individuals starting off in their teens and early 20s kind of reach a peak right in the third decade of life in terms of adaptive skill level, and then it appears to actually deteriorate over time for reasons that we can only speculate about. Possibly the drop-off in services, but there may be other processes going on that may have a biological underpinning or other factors that lead to what appears to be some drop-off of adaptive skill or daily living skill functioning over time. So in the past, most of the drug therapy studies and some that I'll talk about that have finished in the not too distant past, have focused on those comorbid behaviors, not autism per se, but the newest generation of medication studies is really aiming high. We're really thinking about now what treatments might impact the core dimensions of autism, mainly the social, communication, and language deficits, and the other dimension being the restricted interest, repetitive behaviors, and sensory responsivity differences. Now, as far as our success, if you were giving us a grade, our report card would maybe be somewhere in the C plus B minus range. We do have 2 medications that have met full FDA approval for use in children and adolescents on the spectrum, not for autism per se, but for aggression, tantruming, self-injurious behavior. But even the most recent one of those was approved in 2009, 8 years ago. Nothing since. So if you look at it that way, progress has been slow. While medications can be utilized or prescribed off-label, FDA approval really does mean that a treatment has crossed a high bar, both of safety and of benefit. And right now, we're frustrated that we don't have more to show for all of these efforts. But that in no way demonstrates a lack of trying. In fact, the amount of information about the underlying genetics, biology of ASD has exploded, as you've heard earlier today. And a number of possible treatments have been suggested by that research. And indeed, this is an initial list, doesn't even include really all of some of the different classes or types of treatment that have been examined, but suffice it to say that there's been a lot of effort over the last 10 years in particular to find medications that really make a difference. So how have these worked out? So right here is some graphs of some of what were thought to be the most promising candidates. This is a particular study of a medication that selectively blocks one receptor in the brain that has been shown repeatedly in animal models to cure Fragile X syndrome by all measures possible, at least, that one could look at it in a mouse. But when it was tried in people, as you can see here, there was no difference between placebo and the experimental drug. This company didn't stop. They did 3 more trials, and they all were negative, leading to question whether or not this is a viable target. Likewise, one of my colleagues, Chris McDougall and David Posey in Indiana, did an open study of a medicine called D-cycloserine, very safe. It's been on the market for 50 years to treat tuberculosis, and it appeared in this study to benefit social communication. They followed this study up with 60 children randomized to D-cycloserine versus placebo, and unfortunately, when compared to a placebo, it was a bust. Likewise, Memantine is a medicine you may see on TV advertised as Namenda for Alzheimer's. There is a theory that suggests that it might also be effective for ASD. The company that manufactures it took them about 5 years to complete their study, but it ended up being stopped because it was clear that it wasn't benefiting really anyone. So these first set of studies have been very humbling for people like me who focus on this area. There's not going to be any easy or quick solutions to what makes a difference. Oxytocin, as you know, also has been much ballyhooed as a potential treatment. The NIH has just finished the largest study ever completed of oxytocin, and the results have not yet been released. So one can only hope there might be something there. But in a smaller study such as this one, it did not appear to be helpful for repetitive behaviors, which the investigators thought would be the most likely change observed. Another company tried to develop a medication very similar to one that's already on the market, in this case, one called Arbaclofen, which again, in models of Fragile X, were found to be highly beneficial. But despite a number of studies, this agent ended up failing in larger controlled trials that we also participated in. So I'm going to move along. What could explain some of these early disappointments? Well, there's a lot of debate right now about just how suitable some of the animal models really are at telling us what is likely to work in people. There's a lot of debate about that. I don't think it means that animal models are completely uninformative, not at all, but what we look for or how we examine the effects of medications in animals probably needs to be greatly improved. But perhaps the biggest challenge that we face that this audience probably appreciates very, very well is that if you look at a group of individuals with the diagnosis of ASD, they are so different from one another in almost every way. Their intellectual functioning, their extent of anxiety or hyperactivity, their level of repetitive behavior, and so on and so on. And we really haven't gotten our heads around how to best select people who are more like one another, who are most likely to respond to a particular medication and its mechanism of action. So, but let's look at then where we have been focusing a little bit and how I think we're making progress, starting with repetitive behaviors. Now, you may not think of this as the crux of ASD, but on the other hand, if you know individuals who have very severe repetitive behaviors or extreme restricted interest, you know that can consume their mental life 24/7 and forms a very real barrier between a therapist and the individual, or a teacher and that individual. So this is just as impairing as lack of social interest or poor language ability. One of the first studies that we did as a part of a national consortium tested the idea that these behaviors are kind of like obsessive compulsive disorder. On the surface, there is that similarity with the repetitiveness, the stereotype nature of these behaviors and interests. And so we tried an anti-OCD medication, Celexa or Citalopram, and this is probably the most disappointing study I've ever been involved in, because you can't even see the difference between placebo and medication. So the OCD theory really has been thrown out. When we went back, though, and looked at some of the studies of the two indicated medications, risperidone or Risperdal, or aripiprazole or Abilify, what we did find was that even though it wasn't a focus of the study, we didn't recruit people because of repetitive behaviors, we saw that in the risperidone group, they had a greater decrease over 8 weeks compared to the placebo folks. That was significant. Maybe it wasn't enough to brag about at a cocktail party, but it was meaningful, and it was stable over a total of a 6-month period. So that raised the question, maybe these medications or a different medication that shared its properties might work. Similarly, with Abilify, almost the same degree of difference was seen between placebo decrease in repetitive behaviors versus Abilify, or in the second study, placebo versus 3 different doses of Abilify. So again, if we can learn from these studies of what is separating and what seems to be somewhat reducing or helpful, maybe we can figure this out. What we went on to do, that I'll talk about in a minute, is actually study, does risperidone work on the primary endpoint of repetitive behavior. But I'm going to talk about some positive developments with an older medicine, guanfacine, risperidone, insulin growth factor, and folinic acid. So as a part of our ACE Center, we did a study that focused on following up that initial observation from the NIMH risperidone study. But this time, we really put the question to a rigorous test. We asked, if we recruit samples of kids with autism who have high levels of repetitive behavior that's impairing, does risperidone have a clinically significant benefit on that target versus placebo? And what we found was that 42% of the risperidone-treated kids at 8 weeks showed substantial benefit. They were considered responders by raters who did not know what group they were assigned to, didn't know side effects or things like that, and we had a 0 response rate in the placebo group. We're still digesting data from this study, but that looks to be a qualified yes, that relatively low dose treatment with this agent can reduce these behaviors. I would say as well that this was a very mixed group of kids, some more low functioning and as you might guess, had more motor repetitive behaviors, but other kids were in the superior range of intelligence and had more what are like perseverative thoughts, and those also seem to improve. But we need to drill down further and look to see if there's some differential benefit. Obviously, a 42% overall rate means a lot of folks didn't respond. But again, we can learn from this particular test and possibly identify a compound that is indeed even more effective. We recently published another study, also NIH funded, looking at the benefits of guanfacine for the treatment of ADHD in kids with ASD. And you know that probably at least 50% of kids with ASD meet full diagnostic criteria for ADHD. And indeed, in a lot of parent surveys, parents will describe inattention, hyperactivity, impulsivity as among their top 3 or 4 concerns or complaints. So it's a significant comorbidity in that respect. As shown here, we demonstrated that the kids randomized to guanfacine with an average dose of 3 milligrams per day showed a much greater drop in these ADHD behaviors, reduced by about 50% versus those kids with placebo. But one underappreciated finding from this same study is that when we went back and looked at measures of repetitive behavior and inappropriate speech, we saw that kids randomized to the guanfacine arm had a much greater drop in ratings of these repetitive behaviors or stereotypies compared to the placebo group. I'm sorry, this is placebo here, guanfacine here, and likewise inappropriate speech also showed a statistically significant drop as well, suggesting that this treatment, known for its safety, it's been on the market since the 80s as a high blood pressure treatment, might have a clinical utility in some individuals. I want to move on to one more really interesting success story, and one that is generating a lot of attention, in part because it deals with some of the most severely affected children that have an ASD diagnosis, those with Phelan-McDermott syndrome, which is caused by a mutation in the SHANK3 gene. Investigators at Mount Sinai in New York recently published the results of their earliest observations of kids randomized to receive insulin growth factor 1 injections. These are twice daily injections, not so fun, but they did go so far as to compare the kids' behavior after 12 weeks of this treatment versus placebo. And sure enough, they showed that on parent ratings of social withdrawal, or you might say social interest or engagement, the kids receiving the insulin growth factor injections showed greater improvement, and indeed those on placebo showed very limited change. Now, the utility of this treatment is unknown. The safety of it long-term is unknown. And indeed, even in a way, the actual mechanism is not fully understood, except that it does, you can show microscopically that it produces changes in the structure and shape of neurons and synapses that are beneficial and address, or would appear to be addressing, some of the deficits seen in that kind of neuropathologic study of differences in the brains of individuals with ASD. So expect more to follow with this observation. It's a very novel treatment. Equally novel, but maybe harder to appreciate, is a recent report in one of the most highly regarded psychiatry journals of the benefits of high-dose folinic acid treatment. Now, there's been a group of investigators who somewhat controversially have suggested that abnormalities of the vitamin folate are commonly disturbed in individuals with ASD, and thusly that by high-dose vitamin replacement, their autism may improve. Most of the studies to date have been lousy and really don't even merit discussing. But this one was more rigorous. It involved 48 children divided equally into placebo versus high-dose folinic acid. As you can see here, in terms of looking at responders, which was based on a definition of improvement in language scores, they had a 65% improvement rate in the folinic acid treated group versus 24 in the placebo treated group. It was highly significant. So on its face, that was taken by this high profile journal as very impressive. What's harder to understand is the fact that when you look at other things that you would expect to change along with that, here the Vineland Adaptive Behavior Scale communication score, no change was seen in that. So one is left with the uncertainty about, is this clinically meaningful or not? Obviously, the appeal of it is that it's certainly safe for a 12-week period. Don't know about going longer, but we certainly are going to hear more about this down the road. I would just say that other behavioral indicators likewise showed very, very limited change. So I have to say I'm skeptical about it, but I think it's important that you all are aware of such an observation. Then lastly, I want to mention just where we're headed. So going back to the unmet needs for a minute, one of the ones that's most vexing is the fact that we can treat individuals with speech therapy and other communication therapies for hours and hours a week, for years and years and years, and still almost a third of kids on the spectrum never develop functional or phrased speech. That's a huge disability just by itself. But fortunately, Dr. Kazari and Dr. Gulsrud, as you've heard, have been now proving time and time again that their JASPER therapy can make a difference, even in those kids. But when I look at this, and knowing the urgency that families feel about this issue, I want to ask the question, is there any way that we can get to these greater language and symbolic play gains faster, or turbocharge this to get even more gains, potentially by adding the right kind of a medication? So what we're doing right now, and with your help in recruitment perhaps, hoping to finish this before the end of the year, we have taken Abilify because of its unique mechanism of action, which we think might improve the enjoyment of social interaction. And in a placebo-controlled design, we've added that to kids, all of whom are receiving JASPER 3 times a week for 12 weeks, just similar to these studies, and seeing if the Abilify can turbocharge the effect of JASPER. And likewise, I think there's going to be many more studies needed like that, looking at the best of our behavioral therapies combined with a well-chosen mechanism or medication that may facilitate greater growth. So to summarize then, we are making progress. It's frustratingly slow at times, but there are advances that are raising even more exciting questions and studies to be done. We need to figure out ways to get smarter about doing these studies by choosing the right individuals who will do best or get the best response out of a particular treatment. We need to make more friends with our basic science colleagues and talk to each other, communicate about how some of the findings that are emanating from those laboratories need to be rethought or refined, and likewise how some of their measurements could be improved to help them understand the differences between the human condition and the animal behaviors. But all in all, I'd say there's great cause to continue to be optimistic about advancing the use of medications as just one component in an overall intervention plan. So thank you very much.